Hi everyone, we're going to get started now. So thanks for joining us and welcome to the Provincial Human Services and Justice Coordinating Committee webinar on History of Childhood Abuse in Populations Incarcerated in Canada. My name is Tasha Rennie and I am the Communications and Engagement Coordinator for the HSJCC Secretariat. Before we get started, I wanted to go over a couple of things about today's webinar. So we will have some time for questions at the end of the presentation. If you have any questions, please feel free to type them into the chat box on the side of your screen, and we'll try to get to as many of the questions as we can at the end. The webinar will be recorded, so a link to the recording as well as the PowerPoint slides will be emailed to all of the participants after the presentation, and you'll also be able to find them on the HSJCC website. We're also going to be sending out a link to a brief evaluation survey. So I'd ask that you please fill that out, and that will help us plan our webinars better for the future. For anyone who's joining us for the first time, the HSJCC network is made up of 39 local committees, 14 regional committees, and 1 provincial table. Each of the HSJCCs is a voluntary collaboration between health and social service organizations, community mental health and addictions organizations, and partners from the justice sector. Our presenters today are Claire Bodkin and Fiona Kouyoumdjian, and with that, I will pass it over to our presenters.
Thanks so much for inviting us to join you. So today we're going to be chatting about some research that we've been working on for the last few years. So we did a systematic review looking at the prevalence of exposure to childhood abuse amongst folks who have been incarcerated in Canada. And then we use the data from that to do a meta-analysis, which is a statistical analysis, so that we could look at what the prevalence was of different types of abuse. So that's what we'll be chatting about today. And the research was just published in the American Journal of Public Health earlier this year. So a little bit about us. So, Tasha, are you able to give me control over the slides? I just don't seem to have it. Perfect. Okay, so we'll briefly turn our webcam on just so we can say hi to everyone. So I'm finishing my medical school training here at McMaster University and starting family medicine training in July, a residency program. And my training has included some brief stints at the Hamilton Wentworth Detention Center, as well as the Fraser Valley Institute for Women, which is a federal correctional facility out in Abbotsford, and then working with folks who experience incarceration once they're released in the community.
And my name is Fiona Kouyoumdjian, and I'm a family physician. I work part-time at a provincial correctional facility in Hamilton, and I also do research based at McMaster University, which is focused on the health status and healthcare of people who spend time in prison. Thanks. Okay, we also wanted to acknowledge our other project team members, who are Lucy Pivnik and Carolyn Ziegler at St. Michael's Hospital, Susan Bondi at the University of Toronto, Ruth Elwood Martin at the University of British Columbia, and Carrie Jernigan at Columbia University. Claire and I do not have any conflicts of interest. So as many of you who are on the line will know, there is a very large proportion of people in Ontario who experience incarceration every year in Ontario in the provincial system. So we estimate that about 50,000 people are detained or incarcerated, and that's about 1 in every 300 adults. So that's quite a high proportion. And also, as you know, experiences of violence and trauma are very common in this population. And I think that imposes many challenges to those of us who are providing services and healthcare for this population. Okay, we wanted to spend a couple of minutes talking about why it's important to, or what might be some of the ways in which childhood abuse and imprisonment are associated. So we've put up 3 different potential mechanisms here, and I'll just talk through those in some detail. So first of all, it's possible that people who experience abuse in childhood learn that behavior, and that might be through physiological changes in their brain. That might be through understanding violence as a coping mechanism or more of a behavioral change, and that can lead to people perpetrating violence as adults, and of course that can lead to becoming involved in the criminal justice system. So this is commonly referred to as the cycle of abuse. This is somewhat of a controversial theory, and I think there's mixed evidence about it, but that's one potential explanation for why there might be a high prevalence of having experienced abuse in people who are in prisons. The second mechanism, which is mechanism B on the slide, is that child abuse, experiences of child abuse can lead, again, to changes in your brain or changes in your coping mechanisms that could lead to you starting to use substances. And in the context of our current legislative system where drug use is criminalized, that can lead to being admitted to prison. So as a concrete example, someone who experiences child abuse might be more likely to use illicit drugs, and because they're using illicit drugs, they might be more likely to be arrested and taken into prison. So then the third example here of a potential mechanism is that people who are in families that have many challenges, that are chaotic, might be more likely to experience child abuse, and this can include various forms of child abuse, including neglect, might be more likely to end up in prison, and that might also be because the challenging experiences in the family are associated with child abuse. Neglect is a good example, and the challenging circumstances of the family can also lead directly to being involved in crime and ending up in prison. So those are three potential mechanisms. We can't really say which of these is the responsible for the largest part of the association, and that wasn't really the goal of our study, but we did just want to acknowledge that we're not trying to tease these out. All of them, there is some theoretical and evidence base to support each of these mechanisms, but regardless of what the mechanism is, we still need to think about if there is a high prevalence of childhood abuse in this population, we need to think about how this affects the care that we provide, the services that we provide for people who are involved in the criminal justice system.
Yeah. And I think we also just want to acknowledge that these are, proximal determinants or proximal pathways that can result in imprisonment, but of course, experiences of childhood abuse, and particularly the poor parenting family disorganization, is in the context of broader social determinants of health. So just to acknowledge that framing.
Yeah, that's a good point. I mean, another specific example for that mechanism is it might be harder to finish school if you have a lot of challenges in your home life, and so that is also associated with greater likelihood of experiencing imprisonment. Okay, so now moving on to the next slide. The objective of our study was to summarize data on the prevalence of a history of child abuse in people in prisons in Canada. So I'm first going to describe general methods for a systematic review and meta-analysis, and then I'll speak specifically about the methods that we used in our study. So the idea of a systematic review is we're trying to identify all the research and all the reports on a certain topic. So you want to do a very broad search to try to identify as much as is known on the topic. You then undertake a structured process to look through everything that you've identified to see, does it help you answer the question that you're asking, and then to include those reports or studies that do address the question that you're asking. Then from the relevant reports, you want to take out relevant data and also assess the risk of bias. So those are aspects of the methods that might lead the study to come up with a result that is flawed, let's say. And again, I'll talk about that more subsequently. The next step is to summarize the data on all the included studies, and that can be as simple as saying we found 5 studies and each of them found the following results. Or it can also involve, in the last bullet there, conducting a meta-analysis, which is a statistical series of techniques which let you summarize the results across studies. So now thinking about how we applied systematic review and meta-analysis methods to our study, we did a search of 12 databases. So these are large databases, which are primarily available through library access. So through our university librarian, we worked with a research librarian, Carolyn Ziegler at St. Mike's, to conduct a search of these databases. We also, when we found an article that was relevant, we looked through the list of references, and we also looked for gray literature. So that might be things that are not published in peer-reviewed journals. As a concrete example in this area, research published through the Correctional Service of Canada would be an example of gray literature. And we included studies for the past 30 years when we conducted the study, so 1987 to 2017. And then finally, we spoke with colleagues who have expertise in this area to make sure that we hadn't missed any studies that they knew of that were relevant. The next step is going through all the reports and studies that are identified in the search to see whether they're relevant. And we included studies if they met these three inclusion criteria. So first, they had to report data for people in prison in Canada. We limited our search to Canada just for feasibility reasons. And also for policy relevance, because we thought that it would be valuable to be able to say what's happening in our own country. We looked at studies that presented data on people experiencing child abuse at younger than 18 years, and we based that on the World Health Organization definition, which I'll describe subsequently. And then third, we included studies that reported prevalence. In the fourth large bullet here, you'll see that for the review, we had 2 project team members who went through all the titles and abstracts to determine whether they should be included. And they also went through all full text and extracted data from relevant studies. And then the final step is the analysis, where we developed a summary of what the characteristics of studies were, and then we used meta-analysis techniques to generate pooled estimates for each type of child abuse. And we did that for men and women separately if we had enough data to do that. Also if the data suggested that would be appropriate. And again, I'll show you some data that will help to make that more clear. So this is a definition of child abuse by the World Health Organization. Child abuse or maltreatment constitutes all forms of physical and/or emotional ill treatment, sexual abuse, neglect, or negligent treatment, or commercial or other exploitation of children under 18 years of age, resulting in actual or potential harm to the child's health, survival, development, or dignity in the context of a relationship of responsibility, trust, or power. Certainly, this isn't a perfect definition. It's not entirely comprehensive, and some people might say it includes too much. Other people might say it doesn't include enough. Some of the particular considerations that we had in Canada is whether we should also be including experiences of having been in a residential school as a form of abuse. And of course, that isn't covered by the World Health Organization definition. But in the end, we decided that this has enough international relevance and is considered to be acceptable by many. So we decided to go with this definition. Okay, now we're moving on to our results. So in our search, we identified 1,429 records, which we combed through and eventually decided that 34 studies were relevant. So that includes I'll just go through the types of abuse that were described in each of these 34 studies. So as you can see, if you add up the number of studies for each type of abuse, those don't add to 34 because some studies presented data on more than one type of abuse. So only 7 studies looked at whether someone had experienced any child abuse. 23 studies looked at whether people had experienced child physical abuse. 26 studies looked at whether people had experienced child sexual abuse. 12 for emotional abuse, and 8 for neglect. So as you can see, highest number of studies looking at physical and sexual abuse, and we have less data that look at whether people experience any of those types of abuse, and we'll see that in some of the data later on. So we also found that the studies that we identified, the 34 studies, used different methods to collect data. So some of the studies had what I would consider a more rigorous interview conducted to collect those data. And you can just imagine that having a more in-depth interview with people might make it more likely that people would disclose having experienced child abuse compared to something like an administrative file review, which might be, on admission to a correctional facility, having a series of questions on various aspects of your life and your health status, and that could be administered by correctional or health staff. So that might be less likely to lead to someone disclosing having experienced child abuse. And then there were also several studies that used questionnaires. Okay, so I'm going to talk through this table in some detail. So this is the results of the meta-analysis, and I'll just, because I didn't talk about it before, mention briefly. So let's say if we have 3 studies, and one of the studies only included 20 people, and another one included 1,000 people, and then we're combining the results in terms of the prevalence estimates from those 2 studies. As you can imagine, a larger study would have a greater impact on the combined estimate of prevalence because it includes more people. So that's one of the ways that meta-analysis works. It's pooling data from multiple studies, and the number of people involved in a study is relevant to what the pooled estimate ends up being. Okay, so the first line here, so we've got the type of abuse and then estimates for men and women. So for any type of abuse, we didn't have a pooled estimate. So again, a pooled estimate is an estimate that combines data from different studies. There was only one study, and that study found a prevalence of 35.5%. And so it wasn't possible to pool cross studies because there was only one study. In contrast, for women, we pooled data from several studies, and we found that the prevalence of any abuse in childhood was 65.7%. And you can see in the brackets, those are our 95% confidence intervals, so we feel 95% confident that the true estimate lies within those confidence intervals. For physical abuse, the pooled estimates were not significantly different between men and women, so we combined the data for men and women, and we ended up with a prevalence of almost 50%, 47.7%. Then on the next line, for sexual abuse, we found that men and women had statistically significantly different prevalences. So for men, the prevalence of childhood sexual abuse was 21.9%, and for women, it was 50.4%, so significantly higher for women than for men. For emotional abuse, similar to physical abuse, we found that there was no significant difference between men and women, and just over 50% of men and women had experienced childhood emotional abuse. And then in the last line, for neglect, we see that there is a significantly higher prevalence of neglect in women than in men, with men having approximately 42%, reported childhood neglect, and 51.5% of women reported childhood neglect. So we showed the combined data first, but I think that it's important to look at what these data actually look like to have a sense of some of the challenges of pooling data across studies. So this is what's called a forest plot, and I'll talk through exactly how to interpret that. So if you look at the column on the left of the plot, it lists the name of the study, and then the second column shows where the study was conducted. So the first one was Allenby et al. That was a study that was conducted in adult correctional facilities, and they were federal facilities. And the line with the dot in it, the dot shows the point estimate for the prevalence from that study, and the horizontal line shows the 95% confidence interval. So you can see for Allenby that the prevalence of childhood physical abuse that was identified in that study was 39.3%, and the confidence intervals went from 25.6% to 53.2%. So then if you look at all the studies, and this is broken down, you can see all the studies for women only are at the top, and then for men only, and then those that were reported for both men and women combined. So if you look at the dashed vertical line, that shows you when we combine across all these studies that the pooled estimate for all studies, men, women, and men and women combined, was 47.7%. So if you look at an example like the sixth study down, which is Sweetheart, or maybe Sweetheart, I'm afraid I'm not sure how to pronounce it. That study had a prevalence of 27.9%. So that study found quite a different prevalence compared to the summary prevalence. And then if you look at the maybe sixth study down for the males, the Fraser and Roche, that one, they found a prevalence of 83% for childhood physical abuse. So you can see there's quite a range in terms of the prevalences that we included in, for studies that we included in this meta-analysis. And we describe that in statistical terms as high heterogeneity across studies. And so that's something that's important to keep in mind, which is that even though we came up with summary estimates, there is a very wide range in terms of the prevalence estimates that were found in individual studies. So that's one thing I wanted you to take away from this. And then the second bullet here, I wanted to point out that the summary estimates for men and women are similar. So you can see that if you look at the diamond that sort of combines the estimates just for studies at prevalence, estimates of prevalence for women, that diamond is at a very similar place, the diamond for the studies reporting prevalences for men. So for that reason, I'm just going to flip back one slide. You can see that that's why we didn't create separate estimates of physical abuse for men and women, because we didn't think that they were significantly different. Okay, I'm going to move on to the next slide, which is childhood sexual abuse. So again, we have many different studies. We have widely ranging prevalences from not even 10% in the sixth study down there, again by Sweetheart, all the way up to 77.3% in the study by Haney. And then I also wanted to point out that if you look at the diamonds that are pooled estimates for studies of or prevalence estimates for women and the one for men, you can see that those look quite different. So the one for men, the pooled estimate is 21.9%, and the pooled estimate for women is 50.4%. So yeah, so we feel confident that men and women, men likely have a lower prevalence of exposure to childhood sexual abuse compared to women. So in terms of limitations, we didn't present the data on risk of bias, but we looked at two areas that might have led to error in the prevalence estimates that the studies identified. And the first is selection. So ideally, well, the best way to generate a prevalence estimate would be to include everyone. And as you can imagine, that's not feasible for many reasons in this population. Arguably, the next best strategy would be to do a random sample of a population and to have a large sample so that you could be confident that you were accurate in your estimates. And many studies relied on more convenient samples, so people in a certain area or people who consented to participate. So that makes us worried that there might be, that there's a large risk of bias in those estimates. And the other one, the outcome measurements, we've already talked about how certain kinds of ways of asking about experiences of childhood abuse might be more or less likely to have people to disclose their experiences. So some studies we thought were at high risk of bias because of the way that they asked people about having experienced childhood violence. The next point here is the heterogeneity of estimates. So as we saw in those two forest plots for physical and sexual abuse, there is a lot of difference in the prevalence estimates from different studies. And that could be because there are true differences in the prevalence of abuse across different populations. That could be by geography, that could be by the age of people that are included, by sex. It could also be due to differences in how studies defined abuse or measured abuse. So those are all considerations that we have to keep in mind as we're interpreting the results of this study.
So now that we've talked about the study and what we found, we'll sort of talk about, so what's next and why does this matter? I think one thing, as we've been sharing our research with folks, that's come up a lot is for folks who work with this population, people say, well, yeah, of course the numbers are high. We knew that. Like, why did we need a study to tell us that? And I think the value of the study is that we actually, although perhaps anecdotally knew or knew through our own experiences working with people, there wasn't a great sense of nationally how big of an issue this is, and some of the nuances in terms of what types of abuse are more likely to show up in specific populations. For example, higher rates of childhood sexual abuse amongst women who are incarcerated in Canada. So now that we have, finished the study and published it, we're thinking about, okay, well, why does this matter and what's next? So from a research perspective, there's several different things that I think this research sort of launches into or informs. So the first one is thinking about this relationship between childhood abuse and criminal justice system involvement. So as Fiona noted at the beginning, the relationship is not well understood, and there are certainly lots of people who experience abuse in childhood who do not go on to become involved in the criminal justice system. So what are those factors that are preventing involvement? The other side of that coin is, what are the factors that are promoting involvement that make it more likely that somebody who's experienced childhood abuse will become involved in the criminal justice system? And even just comparing the two groups, so people who experience child abuse and don't go on to be incarcerated versus people who experience childhood abuse and do go on to be incarcerated, what are the differences between those two groups of folks? The next is thinking about programs. So I use the phrase or the term programs in the broadest sense. So what are the things that can be done before incarceration, during incarceration, after incarceration, to either prevent criminal justice system involvement in the first place or prevent re-involvement for folks who have already experienced incarceration? So examining how we can modify this relationship. The next thing is policies. So I think it's important to think about not just our individual or institution level work with people who have experienced trauma, but what at the state level is either exacerbating or reducing the likelihood that someone with a history of childhood abuse is incarcerated. So when I think about that, I think about bail policies, I think about the criminalization of substance use, the criminalization of sex work as factors that might exacerbate or attenuate that relationship between childhood abuse and incarceration, and then things that may prevent it. So things like the use of GLADU reports, strengthening and transferring control of child welfare services to Indigenous nations, and how we fund on reserve schools. As if we're underfunding, how might that negatively influence the relationship, or if we're adequately funding, how might that prevent criminalization and incarceration? And of course, there's much more on the policy level. Prevention, so going all the way back to childhood abuse, how can we prevent it from happening in the first place? What is the role of child welfare, the role of adequate funding for Indigenous-led services for Indigenous children, that sort of thing? And how do we reduce the harms associated with childhood abuse? So, for example, if we know that there's an increased likelihood of substance use disorder amongst people who have been abused in childhood, what is the role of evidence-based substance use disorder treatment, particularly within detention centers or within prison? So those are some of the research questions, and of course they overlap with implications for practice. So some of the work that we're building on is from Afifi et al. So they looked at the prevalence of child abuse and then association with mental disorders in Canada. That was research that came out in 2014. And they found that all types of child abuse were associated with all mental conditions. So that included suicidal ideation and suicide attempts. And that was after they had adjusted for sociodemographic variables. The other interesting thing from Afifi's research was that there was a dose-response relationship. So increasing number of abuse types correlated with experiencing greater odds of a mental health issue. So the more abuse you were exposed to, the more likely it was that you would experience mental illness as an adult. So what does that mean for the mental health services that we deliver in prison or to people who have experienced incarceration? I think another thing that we need to acknowledge is that prison can exacerbate trauma-related mental illness. And there's a few, there's probably several ways this happens, but there's a few to think about in particular. So you've got isolation. So people are isolated from their normal coping mechanisms. They're isolated from their relationships that are supportive for them, isolated perhaps from healthcare supports that they're already connected to in community or social services supports. A big thing for trauma survivors is having control over their environment and over their life, and often having a lack of control can be a trigger for a trauma response. So without having control over what your day looks like, or not knowing what's going to happen in the near future, that sort of thing, that can worsen trauma-related mental illness. And then the risk of re-traumatization. So as you can imagine, somebody who has experienced sexual abuse in childhood may find something that is not sexual to still be triggering. So a strip search, for example, could still be triggering for that person and worsen their mental health. When the slide deck goes out, there's a great resource that is listed in the notes, Creating Trauma-Informed Correctional Care, A Balance of Goals and Environment. So I would encourage folks who are interested in specifically thinking about how to navigate this in prison to take a look at that. And then child abuse and incarceration interact with other structural determinants of health. So we chatted about that a little bit earlier on, but for example, familial residential school attendance is shown to affect directly all 5 health and mental health outcomes, higher risk of distress and suicidal behavior. So just knowing that we have overrepresented Indigenous populations in Canadian prisons, there's also this interaction with other social determinants of health. A brief note on what structural determinants of health are. So structural determinants of health include all social and political mechanisms that generate stratification and social class divisions in society, and that define individual socioeconomic position within hierarchies of power and access to resources. So structural determinants are the broader social and political forces that then shape the proximal determinants of health, like experiencing childhood abuse, which then the experience of childhood abuse directly affects the health outcome. I think another important question when we're talking about trauma and why this matters is, what is trauma? So what do we mean when we say trauma? I think that's a word that gets thrown around a lot, and we don't always know exactly what we mean when we say that. So the definition of trauma that I like to use is one that's a subjective individual experience. So it's so difficult to define because people are, interpreting their own childhood experiences and their experiences as an adult in a subjective way. It's culturally bound, and so I think the example of spanking is actually quite helpful in this. In a culture where, I think it's helpful. In a culture where corporal discipline is normal and accepted and everybody is using that experience may still be traumatic for some people because, again, it's a subjective individual experience. But it may not be as traumatic as something that's not sort of culturally normalized or culturally accepted. The flip side of that is that sometimes culture can make forms of abuse can perpetuate them. So I think that kind of cuts both ways. And then trauma includes but isn't limited to childhood abuse. So you can sort of nest childhood abuse under the umbrella of trauma, which of course includes other exposures and experiences. So knowing that there's this high prevalence of childhood abuse amongst people who are exposed or amongst people who are incarcerated, and knowing that trauma has negative health outcomes. I think the next step from that is trauma-informed care. And again, this is something that I think is a phrase that is starting to get used more, that we should become trauma-informed practitioners, whether we're working in social services or corrections or in medicine and healthcare. So I just wanted to unpack a little bit about what we actually mean when we say trauma-informed care. So it was two American scholars, Maxine Harris and Roger Fallett, who are credited with sort of first coming up with this term in the early 2000s. And their vision for trauma-informed care was that the moment a person makes contact with an organization that was providing care, that they would experience this trauma-informed approach. And they envisioned it as requiring a system-level culture shift to account for the unique needs of trauma survivors. So trauma-informed care is where all care, all services are aware and account for the fact that they're serving a population with a high prevalence of trauma histories, and services are then designed and delivered accordingly. So rather than identifying individuals that have experienced trauma and tailoring your response to them once you know that, you set up the whole system to acknowledge that there's a high prevalence of trauma amongst that population. So anybody who's accessing that service sort of by default accesses this trauma-informed approach. An important distinction is that it is different than a trauma-specific service. So trauma-specific service, for example, would be counseling that's specifically designed to unpack and address a person's trauma, versus trauma-informed care, which is where your regular, checkup with the family doctor is delivered in a way where even if you don't talk about the trauma that person's experienced, the way that you give them control over the encounter, the way that you explain what you're doing, the way that you ask for permission is a trauma-informed approach. So one of the big questions for me is, given some of the limitations of carceral environments, can prisons become trauma-informed? Is that possible? And I can only imagine that the folks on the line are also thinking about that and wondering about that, how possible is this? I read an article this week that was in the Edmonton Journal, the Edmonton's newspaper, and it was titled, "What Inmates Think Candidates Should Know About Life Inside Alberta's Jails." Jeff Kent, who spent 15 months in the Edmonton Remand Centre awaiting trial on fraud charges before being transferred to Fort Saskatchewan, was sharing that perhaps the most difficult things about being inside is staying in touch with family. There are no in-person visits at the Remand Centre. Anyone hoping to visit an inmate must do so at a video terminal in a West Edmonton office building. Local phone calls cost $1.25 for 20 minutes. Between travel, phone, and canteen costs, Kent estimates that it costs his family about $1,000 a month for him to be incarcerated and for them to stay in touch with him. Quote, "We're not complainers and we're not grievers," end quote, he said of people in jail. But the reality is this system seems to be designed to separate offenders or alleged offenders from their supports. So I think, hearing about Mr. Kent's experience of being isolated from his supports highlights some of the challenges in prisons becoming trauma-informed. But I really do think that there are a lot of things that can be done. I think that it can start with addressing things like overcrowding, noise, constant lighting, environmental factors, that sort of thing. A big area for improvement could be improving mental health care, so things like evidence-based care for substance use disorders, therapeutic recreation, cognitive behavioral interventions, that sort of thing. Working hard to keep people who are incarcerated connected to their outside supports, whether that's through phone calls or visits. Increasing predictability in the schedule and routine of the day in prison or the week and month. Offering choice when that's available to give people a sense of control over their day and their environment. And working to ensure a smooth transition on release. Training correctional staff around trauma and trauma-informed approaches, and much more. I think the other thing for those of us working in social services and healthcare is using all of the strategies at our disposal to care for people besides incarceration. So thinking about how do we keep people in community and care for them in community. One way of thinking about a trauma-informed approach is this universal precaution approach. So we see this a lot in healthcare or first aid courses or that sort of thing, which is that, you know, before we perform any sort of procedure where there could be like bloodborne transmission or body fluid transmission of diseases, we don't test individual people. We don't ask them if they have HIV. You know, we can't tell from the outside or just from looking at somebody if they have a communicable disease. So we use things like gloves or face masks to prevent transmission and use this universal precaution approach. So I think we can translate that into trauma where we think, okay, rather than necessarily trying to figure out each individual person that we're working with and whether or not they have a trauma history, if we know that the prevalence of childhood abuse and more broadly the prevalence of trauma is high in this population, then we can kind of use some of these universal precautions of a trauma-informed approach to provide good care for everyone that we're working with or good services. And just to credit, it was a researcher named Hodis who sort of first came up with that universal precaution approach. So just a couple of last slides. These pyramids are sort of helpful for thinking about what specifically you can do as a health and social service worker. So you can start either with screening or with that universal precautions approach. So either you're, you know, asking everybody that you work with about trauma in a sensitive and empathetic manner and using that information to inform the services they're being given, or you can use a universal precaution approach that sort of assumes that people have a trauma history. Moving on down from that, you can understand your own history and reaction. So what have your personal experiences with trauma been, and how do you react to people when they share about their trauma, or when they have a trauma-triggered response that's really emotionally heightened or physically heightened or that sort of thing. The next layer is interprofessional collaboration. So knowing what the resources are in your community, who you can refer people to, how to work with the team that you're a part of, both within your organization and beyond your organization to care for people. Below that, understanding the health effects of trauma. So having a sense of how trauma can affect both physical and mental health and making account for that in your service delivery. And then finally, this idea of patient-centered communication and care. So things like meeting people where they're at, which means, you know, accepting them for who they are, what experiences they've had, where they're at in terms of being able to engage with care, that sort of thing. Telling people what you're going to do before you do it, and sort of priming them to expect what's going to come next in the encounter or in the service that you're delivering, and giving people as much control over the setting as possible. So making sure that people are able to say stop or no. For example, in healthcare, we think about this all the time when we're performing sensitive public exams. And then wherever possible, offering a predictable schedule to people, which I know can be sometimes quite difficult when folks are incarcerated and we're not able to inform them when their appointments are happening or that sort of thing. And then adapted a little bit for correctional service workers. So again, this universal precaution approach, but really the other things are sort of quite similar. So understanding your own relationship to trauma and reactions, being able to collaborate with other professionals, whether that's people who are working in the detention center, like your healthcare staff, or working with folks post-release, and then understanding the effects of trauma. And as much as it's possible, being able to see if you're working with, say, a person in your care who is feeling really agitated or escalated, being able to try and de-escalate them without using, say, physical restraint or that sort of thing. So I realize that it's much easier for me to say those things than it is to put them into practice, but those are just some thoughts on things that you might start to think about doing, or maybe you're already doing and you have things to share with the rest of us around how you found that works well, or things that you are having challenges with in your own practice or that sort of thing. So to wrap up, So about half of people in prison in Canada have experienced abuse in childhood. In terms of further research, we want to better understand how childhood abuse affects the risk of imprisonment and what we can do to disrupt that relationship. And we have an obligation, I think, to provide trauma-informed care for this population, whether they're in detention or once they're released into the community, with hopes of both improving their health outcomes and sort of social outcomes, but also preventing reincarceration. So on that note, I'll thank everyone for your attention over lunch and pass things over to Tasha if there's any questions that folks would like to pose to the group, or thoughts that people have to share, because I know this group is working in this area and probably has many, many thoughts and insights and lots of expertise on working with folks who have been incarcerated and experienced abuse.
Great, thank you so much. That was such a great presentation. So we do have about 15 minutes for questions, so I'd like to invite all of our participants to, if you have any questions, type them into the chat box, and we'll try and get through as many as we can. So perhaps we can just give it a minute or so for people to enter any questions. While we're waiting, I was wondering, you were talking about what trauma-informed care could look like in institutions. I was wondering if you're aware of any promising practices that are happening so far in Ontario in terms of trauma-informed care in correctional facilities.
It's Fiona. I was just going to say, I think that there are many individuals who have made great strides, or just came to their jobs with excellent training or natural skills around trauma-informed care. I can't think right now about specific policies or practices that I know of, but that's not to say that there aren't excellent practices and policies in place. I don't know of any off the top of my head. Again, if people can suggest best practices in the chat box, I think it would be great to share that information, because we know people are doing great work in this area.
Yeah, absolutely. Thanks. So yeah, just waiting to see if any questions come in. One moment. Okay, so we have one question here. They're asking, what are the implications for early intervention? So working with youth, the trauma is often fairly fresh.
Yeah, so that's an excellent question. I mean, again, I think the universal precaution approach is important, because that way you sort of are working from this context of assuming that young people who are involved with the criminal justice system have had a trauma history, without expecting them to share all of the details of that or really unpack that. I think something that can be really quite dangerous, actually, is when we ask somebody in great detail about their trauma without them being in a place where they're ready to do that work or interested in doing that work or equipped with the supports to do that work. That can have quite detrimental outcomes for folks. So I think that universal precaution approach is helpful in that it allows you to think about things like, connecting them to the appropriate supports if that isn't you, if you're not a, trauma-focused counselor or that sort of thing, while also thinking about the ways in which you can provide predictability and stability for the young person. And I think the predictability and stability is a big important part of it, and also trying to have that predictability and stability in the relationships that folks have with young people in their care. So those would be the things that I would think about in working with young people. And certainly if there's anybody else on the line that works with young people who has thoughts on what a trauma-informed approach can or does look like for them, it would be great to hear that as well.
And it's, Fiona, just to add on to what Claire said, like a couple of things that are probably obvious to many people. it's just that we appreciate that incarceration is relatively uncommon for youth who are involved in the criminal justice system. So I think a lot of the work of thinking about what it means to provide trauma-informed care and then actually delivering trauma-informed care will fall on community correctional services. So I think that's an important thing. And also, we didn't discuss this in the talk, but some of the more detailed analyses that we conducted in the study did suggest that there is a higher prevalence of experiences of certain kinds of child abuse, in particular sexual abuse, for people who are for youths who are in prison compared to adults who are in prison. So just recognizing that this idea of sort of making it your sort of default approach to assume that people have had experiences of trauma in childhood is probably even more accurate, or an even more accurate assumption that youth have experienced trauma in childhood compared to adults. So just that's a really important thing to keep in mind. And again, I'm sure many people already do have that in mind because of the stories that people tell you.
Okay, thank you. So I have, I think this is a comment here. So they're wondering if you're familiar with the Levels of Service Inventory Ontario Revised Edition. It's an assessment every sentenced inmate must do and covers abuse. Access to this database would tell you about Ontario prevalence, and in their experiences with this population for males is much higher. So their guess would be 80% based on 2000 LFI OR reviewed. They did over 5 years. Sorry, I hope that makes sense. So that's, I guess, a bit of a suggestion for you.
Thank you. Yeah, I am familiar with that tool, and I didn't know that there were data collected on experiences of childhood abuse, but that's really interesting. And obviously, like you said, it's 80%, much higher prevalence than what we found, and it might just be, like, as we discussed, there are very few estimates of any childhood abuse, so if it is a more broad question that's being asked, that might result in a higher prevalence identified. But yeah, thanks for sharing that.
Okay, great. So I have another comment here. Someone saying they believe all services need to be on the same training requirements. Given the social service sector, there are many different backgrounds, i.e. police, prison guards, social workers, the public, even the clients themselves. The trauma-informed training will need facts and research from all sectors and must be delivered to include all sectors to be a success. So I think that's just a comment there.
Yeah, it's Fiona. I would agree with that. I mean, I think, given the varying nature of relationships, of settings, of goals, of interactions, like certainly, I actually don't know if the goal would be to have something that's universally applicable or something that is tailored to the specific circumstances of the relationship, but certainly it makes sense that there would be engagement of people who are using services, like all different kinds of services, as well as people who are providing services, and then people who are working at the level of the oversight administration also.
Yeah, absolutely. Okay, I think that is most of the questions. I mean, someone would just to remind everyone, the recording and slides will be emailed out to everyone. And our other comments are just thanking you for your presentation. So yeah, I want to thank you both for joining us today. That was a really awesome presentation. And I see that your contact information is on the slide there. So hopefully if anyone else has other questions, they can get in touch with you directly.
Yeah, we welcome that. Any feedback, positive or negative, or areas that you think it's important to take this work, whether it's within our expertise or we can share it with colleagues, we'd be happy to receive any questions or comments.
Great. Thank you so much for joining us today.
Thanks for having us, Sasha.
Bye.